the Maurice Bloch Seminar today. Today's speaker is Professor Julie Ratcliffe, who is a Professor of Health Economics from the Caring Futures Institute, Flinders University, Adelaide, Australia. And Julie is also, for those of us in HETA, Julie's an honorary professor here at HETA and also at SHAR in Sheffield. Julie's a long-term colleague and friend of mine. I think we go way back, Julie, way back to our days of Aberdeen at the Health Economics Research Unit. Probably less said the better. That's back in the 90s, I think. So today Julie is going to talk about her work funded by the Royal Commission into Aged Care Quality and Safety. It's really good timing for us. Julie's final report is due out next week, 26th of February, and I think it's safe to say that this work has received a significant amount of media attention. I mean, I'm not going to, Julie, you're going to talk about it, but I think we can say that this research is absolutely novel, and it's likely to lead to fundamental reform of aged care in Australia. And hopefully we can maybe replicate some of this work here in the UK. So I'll pass over to you, Julie, to get started.
Okay, thanks very much, Emma, for the introduction, and thanks everyone for tuning in and for being so patient while we had just a few technical issues at the start there. So the title of my presentation is What Price Quality Aged Care? Assessing the views and preferences of the general public, sorry, I can't spell public, I've just realised, for quality and future funding of aged care. I'd just like to start with some acknowledgements. So this is really a team effort. So I'd particularly like to thank my co-authors, Gang Chen, Jenny Cleland, Billingsley Cambwer, Jyoti Khadka, Claire Hutchison and Rachel Milty. I'd like to thank the advisory group who guided us through this particular project. I'd like to thank Grant Weitzman, David Cullenham and Sam Bai from the Royal Commission into Aged Care Quality and Safety Data Division, and Elizabeth Hume from the ANU for her DC design advice. And finally, the funding support from the Royal Commission into Aged Care Quality and Safety is gratefully acknowledged. Okay, so just a little bit of background, and I apologize, this is not the most technical. This is literally a screenshot of a computer screen. So this was a Google News search that I conducted right at the commencement of this particular project that I'm talking about to you today. And the Google News search was for aged care in Australia, and it was around about September 2019, and this was really in the early stages of the Royal Commission into Aged Care Quality and Safety. And the Royal Commission here in Australia was really brought about by a number of very high profile media stories of really shocking incidences of abuse and neglect of older people in residential care. And you can see, so these are some of the shocking accounts that were actually flooding the media coverage at the time during the early stages of the Royal Commission. And this is some of the evidence that was actually presented to the Royal Commission. Disgraced Bupa aged care facing new allegations of maggots in elderly residents' ear. Physical abuse, use of chemical restraints, the list goes on. So there were some really fundamental problems at that time, which really, magnified the need for the Royal Commission into Aged Care here in Australia. If we sort of move on to August 2020, which was around the time that this particular research project that I'm talking to you today about was completed, you can see we have a whole new series of issues. And I know that this is not unique to Australia. I'm sure these headlines will be very familiar to you also in the UK and many other countries around the world. So flooding the news media at this time is a lot of stories about issues in aged care, particularly COVID-19, which has really ripped through our aged care system here in Australia, particularly in Victoria, also in New South Wales. Fortunately, in South Australia, which is where I'm based, we've been really able to keep it under control. But certainly Victoria and New South Wales, we've had a lot of problems, a lot of older people, particularly in residential care, who died due to the COVID pandemic. Okay, so if we sort of pedal back a little bit to prior to COVID, if we can think about that time before COVID. In June 2019, the Aged Care Quality and Safety Commission, which is essentially the regulatory arm of aged care for the Australian federal government, they introduced a series of new aged care quality standards. And these quality standards were quite far-reaching, and it's the first time we've really had aged care standards of this type here in Australia. Prior to this, we've had very few standards, mainly focused purely around safety issues and clinically focused standards, but these are quite broad ranging standards, and these were introduced really just prior to the Royal Commission coming into force. So you can see they're very older person, family carer focused standards. They're not clinically focused, and they're really about the older person receiving quality care and services, and also services and supports that promote their health and well-being, respect and dignity, etc. And we'll come back to these as we move through the presentation. Okay, so back in the middle of 2019, so the Royal Commission, just to fill you in, for those who may not be so familiar, it's actually was meant to sit for a period of 12 months and report after 12 months. But because of the COVID pandemic, it's been extended for 2 years. It's actually run for 2 years. It's due to complete and hand down its final report next week. So it's been a long process. But back in the middle of 2019, the Royal Commission came to myself and my team at Flinders University with this very tight but quite brief research brief, and asked us if we would be willing to essentially design a survey which would be administered to the Australian community, so to the general public in Australia, about their attitudes towards quality care and person-centred care in aged care, and the community's willingness to pay for that care. And specifically, the research that the Royal Commission asked us to undertake was to provide evidence to better understand what the general community, and by the general community, the Royal Commission were referring to current non-aged care users, because there were other surveys which were undertaken by the National Ageing Research Institute here in Melbourne, which were focused on current aged care users. So this was a survey of non-aged care users, but potential future aged care users in the future, aged 18 and over, about what they would consider to be, or what would constitute in their minds, a satisfactory and high degree of quality and person-centred care for older people receiving aged care services, and also what the community's willingness to pay for satisfactory and high levels of quality and person-centred care would be. And this was including willingness to pay as a taxpayer and co-contributions or fees as an individual at the point of needing to access aged care services. Okay. So our initial challenge then was to think about how we would, design a survey which would go out to the general public, which would really get them focusing on, what constitutes quality of care in aged care. So essentially, we started with a comprehensive literature review of how quality of aged care had been defined in the literature in Australia and internationally. And this coupled with the new aged care quality standards, which I showed you previously, and also industry consultation, so stakeholder consultation with aged care providers, consumers, and other industry stakeholders. So the literature review specifically focused on the Australian and the international literature, and we included grey and peer-reviewed literature relating to quality of care and or person-centred care in aged care over essentially the last decade, so from 2009 to June 2019. We were acutely aware from the outset of the strong interdependencies between essentially care processes, the fundamentals of care, and consumer outcomes, so quality of life and well-being of older people and family carers. And the Commission were quite clear from the outset with us that they would like the quality of care attributes that we identified to be equally relevant and applicable to both home and residential care settings. So essentially, they were focusing on care experience, agnostic of the care setting in which aged care services were being delivered. And the survey was to be developed for an online mode of administration with a target sample size of 10,000 Australian adults. Okay, so we really had to go great guns with this survey design. I think originally the Royal Commission gave us all of 3 weeks, which was totally crazy timeline to develop the survey, but we managed to extend that out to about 6 weeks, I think, which is still not very much time at all to do all the work that we had to do. But somehow we managed to do it. I'm still not quite sure how we managed to do it, but we did. So essentially, it comprised of a series of different sections. So section A was a series of attitudinal statements relating to quality of care in aged care, and these were drawn from the prior literature review and also drawing on the new aged care quality standards in Australia. So we asked our general public respondents about the relative importance of each of these attitudinal statements. We also asked them a series of questions about their knowledge of Australia's aged care system and how they would prioritise these statements. So I won't go through all of the statements, but you can see them there on the screen. Older people should be treated with respect and dignity. Aged care staff should have the skills and training needed to provide appropriate care and support. Older people and their families should be supported to raise any concerns they have with the aged care service, etc., etc. So you can see they're very sort of consumer focused quality of care attributes that we essentially extracted from that process. Okay, and I'll come back to those. The second component of the survey, once we'd gone through the attitudinal statements as a bit of a warm-up type exercise, we got into what we might call the meaty part of the survey. This is in section B. So this was a discrete choice experiment where we essentially focused on the key quality of care attributes distilled down from the literature review, but also through a series of consultations with our stakeholder group, industry partners, consumers, and the research team and the wider advisory group. So we essentially distilled down to 6 key attributes or characteristics defining quality of care. So I'm treated with respect and dignity. I'm supported to make informed choices about the care and services I receive. I receive care and support from aged care staff who have the appropriate skills and training. I receive services and supports for daily living that are important for my health and well-being. I'm supported to maintain my social relationships and connections with the community, and I'm comfortable lodging complaints with confidence that the appropriate action will be taken. And for each of those 6 attributes, we had 5 levels attached to each attribute, and these were common to all attributes. So never, rarely, sometimes, mostly, or always are each of these attributes achieved. Okay, so the DCE design, so we have 6 attributes with 5 levels, so it's quite a large design. So that effectively generates over 15,500 possible profiles and over 122 million possible pairwise choices. So we created an efficient statistical design using the Engine DCE design software. And we applied 2 main considerations. Firstly, we applied an explicit partial profile design, and that was deliberately employed to reduce the cognitive burden for participants, such that for every choice task, and I'll show you some examples of the choice tasks shortly, only 3 of the 6 total attributes varied in each choice task. So only 3 of the levels varied, the other 3 remained constant across the choice task. We had 16 constraints representing highly improbable attribute level combinations that were imposed. And essentially this resulted in 200 pairwise choice questions, which were blocked into 40 versions of 5 choice questions. So we deliberately kept the choice questions that were presented quite brief because this was, remember, this is quite a detailed survey. I haven't gone on to section C and section D yet, which are the willingness to pay questions. So there's quite a lot going on. So we deliberately kept the blocks relatively brief. And we added an additional choice question, which was placed as the common first question in all versions, with a logical response to test respondents' understanding of the DCE task. So I think that's an internal consistency type of check would be the other language for that particular choice question. Okay, so this is the first choice question, which was common, and you can see it's essentially a logical choice. So we essentially asked our respondents to think about if they actually were in need, to imagine that they were actually in need of aged care services, so they'd reached that point in their life when they needed some care and support. And they were offered the choice of two aged care service providers, provider A and provider B, which differed in terms of their key quality of care characteristics. So this is obviously a logical choice that we would expect any person logically to choose provider B, because they're providing the highest levels of all 6 quality of care attributes, whereas provider A is providing the lowest level. Once the person had made their choice, and hopefully the vast majority did, not absolutely everyone, but the vast majority of respondents clicked provider B, then the characteristics of their chosen provider were then represented to them. So essentially provider A disappeared and the respondent was presented with their chosen service provider and their characteristics. They were then asked to a kind of a supplementary question. They were asked to rate the quality characteristics associated with their chosen provider on a like type scale of a quality rating type scale. So how would you rate the overall quality of care of your chosen provider on a scale from unacceptable to very high? And obviously with this particular choice, we expected the vast majority of respondents, as they did, to rate the quality of care as either high or very high. Okay, so this is more of the type of choice that were presented in the remaining questions. So this is an actual choice question from one of the blocks that were presented to our general public respondents. So as you can see, we color-coded the levels also to hopefully make the task a little bit easier. And we bolded the levels where there was a difference between provider A and provider B to make them stand out more. So essentially, our respondents were presented with a series of these types of 5 choices where the levels varied in each choice. Similar sort of process. Once the chosen provider was indicated by the respondent, the characteristics of the non-chosen provider disappeared. They were then asked to think about the provider they had chosen again and to rate their quality of care on the unacceptable to very high quality rating scale. Okay, so in terms of the data analysis, we analysed the DCE responses according to the random utility maximisation framework, which makes the assumption that the respondents choose the alternative, in this case a service provider, that maximises their utility or satisfaction according to the observed attributes, which in this instance were the quality of care characteristics and their associated levels. So we used 2 econometric approaches to analyse the DCE data. Firstly, a traditional conditional logic model, which assumes that respondents have essentially homogeneous preferences. And then secondly, a mixed logic model, which relaxes this assumption and allows for preference heterogeneity amongst the respondents. So essentially the estimated regression parameters are assumed to vary amongst respondents. To account for preference heterogeneity in the modelling, the beta coefficients were specified to follow a distribution using estimates of the mean and the standard deviation. And we selected the optimal model, mixed loaded or conditional loaded, based on the information criteria, including the commonly used AIC criterion and BIC criterion. And for both of these information criteria, a lower value indicates a better fitting model. Okay, so I said there was a lot going on in this survey. Beyond the discrete choice experiment, we also had 2 additional sections. So section C asked a series of questions about the respondents' willingness to pay additional income tax contributions, so in the form of an aged care levy. So here in Australia, the Australian government recently introduced what's called a Medicare levy. So it's an additional, if you like, I can never say the word, hypothecated earmarked taxation support for the health system. So we asked a similar question about whether respondents would be willing to pay a similar type of levy to support the quality of care, or to support the increased funding needed to elevate the quality of aged care in Australia. So a kind of societal perspective income tax contribution. We also asked some willingness to pay questions about co-contributions to support satisfactory and high quality care for oneself or an immediate family member at the time of need, so a personal perspective. I'm not going to go into those particular questions today in the interest of time, but we did ask those questions as well. And then finally, we asked some socio-demographic questions, so age, gender, state or territory, etc. Okay. So the survey questions were pre-piloted and piloted prior to the main survey administration, and the pre-piloting and the piloting took place with Australian adults from a variety of socio-demographic backgrounds, and younger through to older people. And then we conducted the main survey, and this was the online survey panel was sourced through Quality Online Research, which is an online survey panel company here in Australia. There's a number of these, you'll probably be familiar with them in the UK as well. Quality Online Research were sourced by the Royal Commission, so we didn't have, we weren't involved in that particular part of the selecting the online panel company, but we did liaise with them quite extensively over the administration of the survey. In terms of eligibility criteria, aged 18 years and over, able to read and respond in the English language, residing in Australia with no personal experience of accessing aged care services. And demographic quotas were applied to ensure representativeness by age group, sex and state or territory. Okay, so I apologise if this is a little bit difficult to see, but this is essentially the socio-demographic characteristics of our sample. So we, as I said previously, the sample were representative of Australia by gender, age category and state or territory of residence. And then in terms of education, probably, I don't have the statistics in front of me, but probably slightly skewed towards more highly educated people. But in terms of income level, we had a broad spread, and that was probably approaching representativeness. Again, probably slightly skewed more towards people on higher incomes, but we did have a broad spectrum of people on lower to higher annual household incomes. Okay, so again, apologies if this comes across as slightly small, but this is the responses and the results for section A of the survey. So this is where we asked a series of attitudinal statements, and we asked about their relative importance in defining quality of care from the respondents' perspective for Australia's aged care system. So I've highlighted the 3 really salient, most important characteristics. I mean, most of the characteristics, in fact, all of them, as you can see, the majority of respondents indicated were either very important or very important. But the top 3 characteristics were that older people should be treated with respect and dignity. Aged care staff should have the skills and training needed to provide appropriate care and support. And older people should feel safe and comfortable receiving aged care services, whether in a nursing home or in their own homes. Am I going okay for time, Emma? Because I do have a habit of talking too much. Okay.
It's just after 10:30, so about
Okay.
20 minutes, and then 10 minutes for questions.
Yeah. Okay, thanks, because I don't have a clock, so I'm just
don't worry, I'll interject.
Yeah, great. Okay, so we then asked our respondents about their level of understanding of Australia's aged care system. Again, a very simple Likert type scale, so ranging from not at all, so I've really no understanding at all, to I know or I have a level of understanding of Australia's aged care system, which is very good or very well, is the way we phrased it. So you can see here, this gives the breakdown of responses to those particular questions by gender and also by age group. And you can see that that's remarkably consistent actually across the age range and across genders as well. So there's probably around 2/3 of our sample indicated that they understood Australia's aged care system or thought they understood Australia's aged care system to some degree. So either somewhat, fairly well, or very well, which is the grey, the orange, sorry, the grey, the yellow and the blue on this particular graph. Okay. So for those people who indicated that they understood Australia's aged care system either somewhat, fairly well or very well, we then asked those people only, so that's a proportion of our overall sample, a series of follow-up questions. So we then asked them to pick out essentially their top 3 statements, quality of care statements or quality of care priorities in their opinion for Australia's aged care system moving forward. And that we also asked them about Australia's current success in achieving each of these quality of care priorities. So you can see again the 3 main priorities from the general public's perspective were that older people should be treated with respect and dignity. And in terms of Australia's current success at achieving that particular quality of care characteristics, the vast majority indicated that that was only sometimes, rarely or not at all, with much fewer, probably around a quarter, indicating often and just under 7% indicating always. Older people should feel safe and comfortable receiving aged care services, whether in a nursing home or in their own home. Again, so you can see a similar pattern with probably around 34% indicating that that was often or always achieved, but the majority, 64% or so, indicating sometimes, rarely or not at all. And finally, aged care staff should have the skills and training needed to provide appropriate care and support. And again, a very similar pattern with around 34-35% indicating that Australia's aged care system was performing relatively well, so often or always achieving that particular quality of care priority, but the majority indicating sometimes, rarely or not at all. Okay, so this is the results from the discrete choice experiment. So these are the conditional logit estimates, but the mixed logit estimates actually, although I'm not showing them today, were really very, very similar to the conditional logit estimates. So what you can see on this particular figure is the relative importance of each of the levels, with never being sort of the base level, each of the level increments in improvements in each of the 6 quality of care attributes. So what you can see here is that the older person being treated with respect and dignity is really a very important characteristic, followed by the level of skills and training of aged care staff, and that the older person receives services and supports from the aged care provider which promote and maximise their health and well-being. Okay. So the next stage was to focus on the quality ratings. So in total, we had a target sample of 10,000. We actually achieved a sample of 10,315 respondents, and each respondent provided 6 quality ratings, which should have produced 61,890 observations, I'm reliably informed. But there was a technical issue with the online platform, which meant that responses of one DCE task from one person were not actually recorded. So that led to one missing observation, and we've no idea why that happened. It's still a mystery even to this day. So essentially we were left with 61,889 valid observations, and of these 10.3% of the scenarios which were chosen were rated as very high quality, 13.9% were rated as high quality, 32% rated as satisfactory quality, 30.2% rated as poor quality, and 13.5% of the chosen scenarios were rated as unacceptable. So in analysing the quality ratings in a regression analysis, we essentially amalgamated the bottom two quality levels and the top two quality levels, so that really to sort of streamline the analysis and make it easier to interpret, we were making a comparison amongst three key quality levels. So unacceptable or poor, satisfactory, and high or very high quality ratings for those chosen service providers in each DCE choice. So a multinomial logic model was applied to this data, and a set of two equations were estimated, one for each category relative to the reference category, where the reference category was satisfactory. Okay, so this makes it a little bit clearer. This is the figures relating to each of those analysis. So on the left-hand side, we have satisfactory quality compared with unacceptable poor quality. On the right-hand side, we have high or very high quality compared with satisfactory quality. So if we focus on the left-hand side first, what you'll notice is that those the magnitudes of the columns attached to each of the 6 quality of care attributes is really quite similar to the initial DCE results, where we asked respondents to indicate the chosen provider. So this is a quality rating, which is a slightly different task. You can see the results essentially magnify or mirror in many ways the findings from the discrete choice experiment. So when thinking about these graphs, what we're really thinking about is, what are the characteristics which would shift a respondent or respondents in total, would shift their quality rating from unacceptable to poor to satisfactory. So you can see here it's all about respect and dignity, number one, followed by the skills and training of aged care staff and services and supports that promote the health and well-being of the person. When we look to the right-hand figure, we're then looking at, well, what are the characteristics which really shift a scenario, so the chosen service provider, from being rated as satisfactory to high or very high quality. And you can see here the really salient characteristics are where each of the quality of care characteristics is at their highest level, so always provided. But also you can see the added implication or the added importance of the ability to lodge complaints with knowledge that the appropriate action will be taken as a really salient characteristic that comes to the fore when we're thinking about how respondents rated scenarios, or what would shift respondents in their quality ratings from satisfactory to high, very high quality. So the ability to lodge complaints with knowledge that the appropriate action will be taken was really important also in defining high or very high quality rated scenarios or quality of care scenarios. Okay, so moving on now to section C. So I just wanted to give you a few highlights here, and I'm really focusing purely on the highlights in relation to the income tax contribution questions and the societal perspective. So we asked a series of 4 key attitudinal statements about aged care funding initially. So we asked our respondents to indicate their level of agreement with each of these key statements. So the government should provide more funding for aged care, and you can see that an overwhelming overwhelming majority, so approximating almost 90% or moving towards 90% of our respondents either strongly agreed or agreed that the government should provide more funding for aged care. But you can see that when we get into the more thorny questions, if you like, about how that might be financed. So I would be willing to pay more tax to ensure Australians are able to access aged care services when they need them. A lot more variation. So in terms of strongly agree or agree, around 50% of our sample either strongly agreed or agreed with that statement. 34% neither agreed nor disagreed, with around 16% disagreeing or strongly disagreeing. Australians should contribute towards the funding for the aged care services that they receive in line with their ability to pay. More agreement with this one, and I think that is because at the moment in Australia we do have a co-contribution system. So just by way of background, Australia's aged care system is currently funded principally from income tax contributions and from co-contributions from older people at the point of access. And in terms of the breakdown of that sort of funding, it's around 75% funded, Australia's aged care system, 75% funded through income tax contributions at the moment, and 25% through co-contributions. So we found, probably not surprisingly, that the majority, almost 70% of our respondents either agreed or strongly agreed with the co-contributions, because that's sort of the norm, if you like, at the moment in Australia. I would be willing to pay more tax to improve the quality of aged care services being provided to older Australians. Again, similar to statement 2, so a bit of a range, with around 50% either strongly agreeing or agreeing, and 33% neither agreeing nor disagreeing. Okay, so then what we did is we asked our respondents if they were current income taxpayers, and approximately 2/3 of our sample, which is in line with what we would expect for a general public survey of this type, and in the general population, the Australian general population. So around 2/3 were current income taxpayers, because we had, you know, people from 18 to 91 in this survey. So we had a lot of retirees, quite a lot of students. So around 2/3 income taxpayers. So we then asked the income taxpayers some supplementary questions. We asked them about their willingness to pay an aged care levy, so financed through increased income tax contributions. And we gave them a payment scale type of question, where initially we asked them, it was a 2-part question. So initially we asked them, would you be willing to pay any increased income tax at all to support, firstly, satisfactory quality aged care for all Australians in need, and secondly, high level quality aged care for all Australians in need. So that was a kind of yes, no question. And we asked the satisfactory first, and then moved on to the high. So we started with satisfactory. If someone indicated yes, they would be willing to pay more, we then asked them a supplementary question, which was how much they would be willing to pay. And we had a payment scale ranging from 0.5% increased income tax per year to 2.5% increased income tax per year. And then an open question, which was more than this, and they were prompted to indicate how much more than this they would be willing to pay. So these are the top figure, or the top table, is the satisfactory quality aged care. So essentially 61% of our income taxpayers indicated they would be willing to pay more income tax to support what they perceive to be a satisfactory level of quality aged care. Of course, it's quite subjective. We deliberately framed this question. We asked respondents to think about their previous responses to the DCE in their head. So it's quite a, you know, arguably a difficult task. We didn't present them anymore, but we said, you know, think about the DCE you've just undertaken, think about the quality ratings that you gave for satisfactory level of quality aged care, and then indicate how much you would be willing to pay to achieve that, essentially. So these are the responses, and you can see that they spread throughout that payment scale continuum, and the average amount that our respondents indicated they would be willing to pay, the ones who said yes, that is, so the 61%, was 1.4%. That was the mean. The mean was, I think, a slightly higher, 1.7% from memory, but the mean was definitely 1.4%, because that's in my head, because the media were only interested in that figure, I can tell you. So it's definitely correct, the mean. Then For those respondents, and those respondents who indicate, we then asked, actually it wasn't for those respondents who only indicated yes, we asked the same question about high level quality aged care. So we replicated the same question. Would you be willing to pay more tax? Yes, no. For those that said yes, we then asked the same payment scale question, but we asked them to indicate what they would be willing to pay on top of what they previously said they would be willing to pay. So that was piped back in. So the amount that they'd said they would be willing to pay for satisfactory quality aged care for all Australians was piped back in. They were asked if they would be willing to pay more than that to achieve high quality aged care. And again, what they perceived to be based on their previous DCE responses. If they said yes, then we gave them the payment scale questions again. So again, you can see the spread here. In terms of how that quantified overall, the mean additional willingness to pay to move from satisfactory to high level quality aged care was an additional 1.7% beyond the mean the original mean, which was 1.4%. So overall, to achieve high quality aged care, if you aggregate those two together, two amounts together, it's around 3%, but 1.4% mean for satisfactory and an additional 1.7% beyond that to achieve high level quality aged care. Okay, I'm on to the discussion now. I think this is actually my last slide, so hopefully I'm all in good time, Emma. So
that's perfect. I was just about to say a couple of minutes left and then we'll have some
right.
time.
Okay, perfect, because I'm pretty sure this is my, in fact, I'm sure this is my last slide.
Thank
so,
you.
In terms of the discussion and the conclusion from this work, we found there was generally a high level of agreement amongst members of the general public about what constitutes quality of care for Australia's aged care system. Salient characteristics consistently rated as highly important in encapsulating quality in aged care service delivery are really largely reflective of what we would call the fundamentals of care or person-centred care. The deficiencies in this regard, particularly in relation to understaffing and the need for more training, skills and training of aged care staff, have really featured very highly in media reports throughout the proceedings of the Royal Commission here in Australia. So I think they're really salient in the general public's consciousness as a consequence of that, and of course of all the shocking tales that were presented in evidence in the early stages of the Royal Commission. We found that the results from the supplementary quality ratings task were similar to the results from the DCE, particularly when we think about the comparison between low quality and satisfactory quality. When considering the characteristics that elevated a provider from being rated as satisfactory to high or very high quality, we saw that the additional importance of the ability to lodge complaints with confidence that appropriate action will be taken, that became quite salient and quite evident. And in summary, the findings provide an important and timely societal perspective, certainly here in Australia, you know, with the Royal Commission about to hand down its final report. So hopefully these findings will be informing aged care policy and practice in Australia, and also the aged care reforms, which will most certainly come out of the recommendations of the Royal Commission. And in other countries, potentially the UK, we're hopeful that we can work with you guys, particularly with Emma and colleagues, to maybe replicate some of this work in the UK moving forward. Would be really exciting to do that. And the UK is, of course, a country which shares very similar values, aspirations and circumstances to Australia. And I think that was all I had to say, Emma. So thank you very much. And if you're interested and you would like more details, the research paper which we produced for the Royal Commission on this work is available on the Royal Commission's website. Thanks, Emma.
Julie, thank you so much. That was so interesting. It's great to get the detail behind the survey, and also, you know, just the science behind the choice experiment, which obviously, you know, is such a useful technique in health economics for providing these values. And I know there's a lot more to these surveys that you haven't had a chance to go through today, but I mean, I've got a number of questions, but I noticed John's got a question on the chat. John, I don't know, do you want to speak to this, or? I'm happy to read it out. So John had put on the chat, Julie, that Portugal has recently legalised assisted dying. And he wanted, in Belgium, he was saying that 1 in every 20 deaths is by legal administration. And he was wondering whether whether you'd looked into this at all. You know, the right to choose to die is all intertwined with human dignity, right? And that's coming up as a top attribute. So I think John's question speaks to that.
Yeah, no, that's a really good question, and it's a very hot topic at the moment in Australia. Yes, it's quite controversial. I do believe that Victoria has just introduced some legislation which does allow, in very specific circumstances, voluntary euthanasia, but that's the only state in Australia. So we have six states and territories across Australia, or 7, can't remember exactly, 6 or 7 in total. That's the only state that's allowed it. It's very controversial, I know, at the moment in South Australia. We don't have any legislation that allows it here in South Australia at the moment, but that's a really good question.
Thanks, Julie. So Daniel White is asking a question there. Did you consider asking the public's opinion about funding better care through tax on wealth rather than income? With the background being there's increasing evidence that inequalities in wealth are very important for inequalities and well-being.
Again, that's also a very good question. We were guided in this particular, that would be something that, well, that's definitely an area that I would like to do more work in. We were guided by the Royal Commission's brief here, as you can see. It was quite tight. They were really wanting us to focus in this particular survey on the current funding sources for aged care, which in Australia here are predominantly income tax, 75% income tax funded, and co-contributions at the point of access. But that's a really good question, and it's certainly something which has been debated here in Australia, and it's something I would like to look into in the future, about a person's wealth and whether property, you know, should come into the equation somehow. We did have Paul Keating, actually, who's some of you will be familiar with Paul Keating, former Prime Minister of Australia, who did actually give evidence at the Royal Commission on his proposal, which I think got mixed reception, but that was a proposal about paying for aged care through someone's estate once they died, I think, which got a lot of media attention and a lot of mixed interest. Some people loved it, some people hated it. But yeah, there's lots of potential future funding mechanisms for aged care, and we know in Australia, as in the UK and lots of other countries, that the income tax base will shrink anyway. So even if we do have general public support for increased income taxation, over time that funding base will decrease because of the ageing of the population, and the ratio of the working population to the proportion of older people needing to access aged care is going to shrink in the future. So we do have to think about alternative funding sources for Australia's aged care system, and I guess you've got the same issues.
Yeah, absolutely. Janet's got a question here. Did you go into anticipatory care planning at all? You know, it obviously plays into dignity and choices in terms of own care.
Yes, that's a very important topic. We didn't go into that in this particular survey, but it's certainly an issue that has been raised on numerous occasions for the Royal Commission, and a lot of the evidence that was presented included evidence around advanced care planning, palliative care and aged care, etc. So it's certainly a very important topic, but it wasn't a topic that was included in this particular survey.
Thanks, Julie. And John's coming back on his assisted dying. Is there what's the public support for assisted dying in Australia? Do you have a sense of that?
I think if we did a referendum tomorrow, there'd probably be a majority. I wouldn't like to say how much of a majority, but I think there is a majority of public support for it. I think it's probably only a matter of time. We have a number of very high profile clinicians who are very anti going down that path, and I think, and obviously, you know, there is a proportion of the general population who for various reasons don't agree with it, but I think I don't have any empirical evidence, Emma. I mean, I think there is. Having said that, I think there is.
Julie, don't worry.
I don't think it's. I think it's main, small, relatively small samples that of the Australian general public have been surveyed, and it tends to be a majority, but it's not the overwhelming majority that agree.
Julie, we've got a couple of minutes left. I just wanted to press you on the impact that this has had in Australia. Obviously, quite significant. I mean, I was reading through your long list of interviews and media hits and newspaper coverage, and I mean, this has received a huge amount of attention in Australia. It's likely to have significant impact. Can you say anything more about the reforms that are planned and the extent to which your research is feeding into these reforms?
Well, that's again a very good question. So the Royal Commission is due to hand down its final report at the end of next week. And we expect that there will be recommendations about future funding and the need to think about future funding and possibly to increase income tax. But we already know the government is signalling that they're not overly keen on increasing income tax for any reason at the moment. Probably maybe a similar situation into the UK, I don't know, because obviously with COVID, the economy's already taken a major bashing. So we're not sure whether that will actually get introduced, but there does have to be funding found from somewhere. So that was also another component of the survey that I didn't have time to go into, but we did ask our respondents about whether they thought we should be reallocating public expenditures towards aged care and away from other public services, and a lot of people said yes, although I don't know that they were really thinking about the opportunity costs of their decisions when we asked them that question. So I think there will be a reallocation of public expenditure towards aged care, but I think that will likely happen, but whether they'll go as far as increasing income tax, I'm not sure. There are a number of other recommendations around elevating the quality of the system, though, so it's got to be funded somehow, Emma. So, but I think the most likely scenario, at least in the short to medium term, is that the funding will be found by reallocating public expenditures away from other services rather than necessarily increasing income tax contributions per se. But we'll just have to wait and see. Yeah.
Thank you, Julie. It's so interesting. I'm really looking forward to. I think we'll hopefully get you back in the future to come and tell us about the rollout of this work and the real impact that it's had in the future. But that's 11 o'clock now, so, and I haven't seen any other questions on the chat, so I'm going to say thank you very much to Julie for a fantastic presentation, and thanks to all our audience and for the great questions. So thank you very much.
And I'm just really sad that I couldn't be there, because obviously that was the original plan, that I would be there. Of course,
I know. But I think we're going to be having further discussions, Julie, about replicating this work in the UK. So I might be looking out for a nice PhD. So with my postgraduate convener hat on, if anyone's interested, come and speak to me.
It would make a fabulous PhD.
Yeah, I think so.
Yeah.
Well, thank you very much, Julie.
Okay, thank you.
I'll drop you an email right now. We'll maybe have a brief catch up afterwards. Lots of